So we're going to talk a little bit about the adolescent health visit and then get into some other categories that are outlined here for you. And there's no doubt, and you well know, that most adolescents don't want to come and see us. And oftentimes when they do seek care, it's not in an office. It may be in a school-based health clinic, or it may be in an emergency setting. And although this may seem obvious that minor chief complaints are common, keep in mind, and especially even for your boards, that if the chief complaint is sore throat, but if there's a comment about does not maintain eye contact or has difficulty sitting still, that might be a hint that the chief complaint is nothing more than an excuse to get to see you for something that for the adolescent is much more problematic. So as you get questions on your exam in regards to adolescents, you're going to want to focus on several things: preventive counseling, health maintenance needs, health supervision, and immunize. And we'll be talking Saturday morning about immunization. It's important that you know for the test, because this is a pretty straightforward question if you get it, that there are specific causes of morbidity and mortality that change a little bit between early adolescence and late adolescence, but it's something that you should commit to memory unless you get, in case you get a straightforward question. And in regards to the specifics about unintentional injury, you should also know how these differ a little bit, again, between early and late adolescence. Now, you can see that I had a little trouble typing this because there's not enough E's and there's not enough D's on this mnemonic. And I think my preferred mnemonic is the heads first mnemonic, which I would suggest that you learn. And I would suggest that you learn this because if you keep this in mind, if you get a question about health maintenance, if you get a question about preventive topics that you should discuss, this mnemonic may help you to focus on the correct answer on your boards. And it's pretty straightforward, but it does allow, at least for me when I'm seeing a patient, to make sure that I don't leave out anything important. There will definitely be questions about confidentiality, what you need to keep confidential, when you should break confidentiality, and the like. And one thing that is strongly encouraged by the AAP is to begin to talk to not only the very young adolescent, but even in the 8 to 10-year-old age group, talk to that individual alone and discuss the importance of that with the patient's parent. And then once you reach the adolescent age group and you're dealing with things that are oftentimes much more personal and much more worrisome, the adolescent is relatively used to speaking to you alone, and the parents are relatively used to the fact that their adolescents are behind closed doors without them. And why is that so important? It will help the adolescent be more willing to come to see you if he or she feels comfortable with you when alone, promotes a sense of autonomy, and very importantly, it protects the adolescent from the potential of humiliation or discrimination, especially in regard to the more sensitive topics. The answer for the test is that if parental notification is likely to in any way impede the adolescent from seeking necessary treatment, that physician should provide care without parental consent. Now, what are the exceptions to that? Because they like to ask about exceptions. Certainly, if there's any concern about physical, sexual, or emotional abuse, if you are concerned about the potential for risk of harm to self or others, or if there's noncompliance with a serious disease, your patient has a hemoglobin A1C of 10, or they have an inflammatory bowel disease and are not caring well, for themselves. But in general, with this exception, the answer for the exam should always be that care can be provided without parental consent. Now, in the real world, you're going to have to know what your laws are in the individual states. And so it's different from state to state in terms of contraceptive access, for example. It's different in state to state in regards to treatment of STIs. But in general, if you take the last 3 or 4 slides and remember those points from a board perspective, you should do just fine. Now, there are also exceptions to this in regards to emancipated minors. So if an individual minor has moved out of the home, or if they're married or in the military, then what I talked about over the last several slides does not have any relevance. Now, show of hands, how many people know a minor who is financially independent? Okay, really? Okay, so I need to talk to you because my 30-year-old I sometimes think is not financially independent. So I would request your help. And as the people with med study know, I also have my first daughter getting married, and I'm absolutely panicking. She is not financially independent for this. So keep these exceptions in mind. You'll clearly get asked questions about developmental stages of adolescence. So they become adults, they become more independent, they become much more peer-focused. They're faced, I don't have to tell you this, with lots of choices, many of which will potentially cause them harm. And they are moving from a rather sheltered or oftentimes very sheltered home environment into an environment where they're going to have, as I said, lots of choices to make. So there are some key things to keep in mind for your boards when it comes to developmental stages in adolescence. And what I did for the next group of slides is to try to put the one key word to keep in mind, or the one key phrase to keep in mind for the early, mid, and late adolescent age group. So concrete cognition, along with these 3 or 4 additional topics. If you see any description of an adolescent, this is sort of the adolescent example of a developmental question in a 9-month-old. You may get a question on your exam that says a child speaks 2 words, grabs with a pincer grasp, and recognizes his mother and dad. How old is this child? Well, this is the adolescent equivalent of this. So you really should know the transitions and know the particular characteristics associated with each developmental stage. But what I attempted to do is to pick out the ones that are most relevant, that you'll most likely see on your board exam, and they're bolded and in yellow. So concrete, cognition, simple, explicit discussions, etc., are much more typical of an early adolescent. And then, you've all seen this, the mid-adolescent has no fear, thinks they're completely omnipotent, and immortality. During this stage of my 2 boys' teenage years, I think I built the orthopedic office just based on their multiple injuries. It was almost becoming, well, it wasn't a joke, but it almost was a joke. So they think they can do anything and they'll never get harmed. And then, so this obviously leads to a lot of risk-taking behavior. Very importantly, they move away from peers and begin to explore relationships with the opposite sex, and conformance with peer values, with dress, with interests are very important in the mid-adolescent age group. And you can see some other characteristics of this age group, which I think you might be a little bit less apt to be asked about, but they're included here for completeness' sake. Now, the late adolescent is really much more idealistic. They're out to change the world. They will resolve the world's problems, and that idealism is sometimes associated with some black and white opinion as well, in terms of it's got to be this way and it cannot be that way. But at the same time, life goals are becoming more important. Individual relationships replace the peer group. So the older adolescent is much more comfortable and much more interested in a particular relationship or a small group of friends rather than, for lack of a better word, running with the pack as the individual in early adolescence or certainly mid-adolescence is. They tend to be a little bit more comfortable with themselves in terms of body image. And they're beginning to circle back to their parents, beginning to understand that maybe some of what their parents advised should be at least considered, if not followed. So keep these transitions in mind and look on your boards for what I'm calling the adolescent equivalent of the developmental age of a particular younger child. So hopefully and ideally, you're having the parents as active partners in the care of their children. There is some give and take between the adolescent and his or her parents. And these particular 6 topics are topics, again, that on your boards you might be asked about in terms of the parent-adolescent relationship versus the last 3 or 4 slides, which were more focused on the adolescent themselves. There's a lot of differences over the last couple of years and a lot of new recommendations in terms of screening. And I want to say that even since I submitted these slides, there have been some changes as well, which I'll highlight to you. So screening recommendations that we're going to review are outlined here, and let's go through these in a little bit more detail. Keep in mind the various risks that are associated with cervical cancer, multiple partners, previous history of STIs or STDs, especially a previous history of HPV infection or a previously abnormal pap smear. Keep in mind that HPV is the most common sexually transmitted infection in the United States. And this is one of the few times that I would recommend to you that you memorize serotypes. I don't think it's very important for the vast majority of organisms, but because there are specific serotypes associated with cancer, 16 and 18, which make up about 70 to 75% of all cervical cancers, and then 6 and 11, which account for at least 90, if not 95% of all genital warts and the like. And so I think this might be a fair question on your exam. So how do you vaccinate? So there are 2 HPV vaccines available, one approved in both males and females because it does contain 6 and 11, and the second only approved in females because it only contains 16 and 18. And remember, and we're going to talk about immunizations on Saturday morning, but if you do miss out on the opportunity to vaccinate at the 11 to 12-year-old visit, catch-up vaccination is important. You do not have to restart the series if it's been 6 months or a year or 2 years since the series was started. A question that you might get around that would be an individual who has an HPV vaccine, then becomes pregnant. You don't see her again for 12 or 15 months. She presents to your office. Do you have to start the vaccination series over again, or can you count the initial one? And the answer is that you can count the initial one. And that's pretty well true for all immunizations. In addition, remember that a previous history of HPV is not a contraindication to the vaccine because it's very unlikely that an individual woman would be infected by all the serotypes that are provided through the vaccine. And those are the 2 most common things. Do you have to repeat the vaccine schedule, or is a previous history of HPV a contraindication? So for the first audience response, in which of the following patients is a pap smear recommended? An 18-year-old with 3 lifetime sexual partners, a 19-year-old prior to initiating oral contraceptives, 17-year-old with 2 sexual partners who has not yet been vaccinated with HPV, a 21-year-old with 1 sexual partner, or an 18-year-old with a sexual partner recently diagnosed with gonococcal urethritis. Good. Okay, so D is the correct answer, and this is a somewhat new recommendation, not brand new, but relatively new, and that is that cervical cancer screening should not be initiated until 21 years of age, and that is regardless of the age of sexual initiation and other risk factors, and it should be repeated about every 3 years. Whether you've been vaccinated or not does not change these recommendations, and it's thought that it is perfectly safe to wait until 21 years of age because the vast majority of adolescents who do become infected with HPV, the cellular changes revert back to normal over a period of several years, and this avoids overtreatment. So this is an attempt to prevent a 19 or a 20-year-old from going for a colposcopy, for example, causing damage to the cervix and potentially placing her at risk for difficulty with carrying a pregnancy when she is older. As everything, there's always an exception, and the exceptions are pretty straightforward. If there's a history of cervical cancer, if for some reason the individual had a pap smear that was very, very abnormal, and again, I can only think of a couple of instances where that might happen, or, and this is the board question here, if they are immunocompromised or HIV positive. Then the recommendation is to screen them twice within a year of diagnosis and then once a year thereafter. Okay, HPV co-testing is not recommended because, again, although it's a very common infection in adolescents, the vast majority of infections resolve over a period of a couple of years. And I can see this being a question on your exam. And again, the reason for that is it decreases the potential for unnecessary treatment that may ultimately compromise the cervix. And in fact, the recommendations are not to begin co-testing until 30 years of age. Mucopurulent discharge is not a contraindication to a pap smear. Pap smears are better done not during the time of menses, and you can collect specimens for STIs and not be concerned that the process of collection in any way would adversely affect the validity of the pap smear. So who should you screen for STIs? So you need to keep in mind the risk factors. Again, it's the adolescent age group. It's an individual with a previous STI or multiple partners or a partner with multiple contacts or a partner with an STI, inconsistent condom use, commercial sex work, and illicit drug use. So these are pretty straightforward and obviously would place an adolescent at risk of an STI. So let's say that you have diagnosed a 19-year-old with gonococcal infection. You treated him appropriately. When should he be retested? A week, 2 weeks, a month? Retesting is not indicated, or in 3 months. Okay. Actually, the recommendation is to retest that individual in 3 months. Okay. And this is a relatively new recommendation as well. And let's talk about that a little bit. When should you screen? When should you retest? You should screen all asymptomatic sexually active females annually for both gonococcal disease as well as chlamydia. That same recommendation does not hold true for asymptomatic sexually active heterosexual males. The important point there being heterosexual males. All individuals diagnosed with either Neisseria and or chlamydia infection should be retested 3 months after treatment. The thought there is that retesting 1 or 2 weeks after treatment is probably not going to be as high yield as waiting for a longer period of time. In essence, for lack of a better word, giving that individual the opportunity to be reinfected. HIV testing is universally recommended for all sexually active adolescents and should be repeated annually at high risk. Now, after I made this slide, the Bright Futures was updated by the AAP. And the update to this statement, although I don't think it's going to be on your boards, but the update to this statement is that individuals between 16 and 18 years of age should all be tested for HIV if the incidence of HIV in the community is 0.1% or greater. So rather than just screening the sexually active individuals, the recommendations have taken that a step further and recommended screening for all 16 to 18-year-olds if the incidence of HIV is at least 0.1%. Routine screening for syphilis, for trich, for bacterial vaginosis, for herpes, for HPV, hepatitis is not recommended. Now, if you have a patient who is a male who is having sex with other men, then screening becomes more detailed, and you should keep this in mind. So, annual screening is recommended: HIV, syphilis, and if a syphilis serology is positive, confirmatory testing is important. So if you have a positive RPR, you've got to confirm that with a specific treponemal antigen test. For example, an FTA or an MHA-TP. So syphilis serology, urethral infection should be checked for in the urine, and off-label, it's also recommended to get rectal swabs for rectal infection with both gonococcus as well as chlamydia. In addition, pharyngeal infection, again off-label, but it is recommended for gonorrhea, but it is not recommended for chlamydia. So urine and rectal cultures for both GC and chlamydia, oral cultures only for gonorrhea. And if there are multiple partners, the yearly screening may have to become more frequent, down to even 3 to 6 months, especially if they have a number of anonymous partners. And finally, a single one-time screen for hepatitis B is recommended in this population of individuals. And on your boards, you may be asked about various infections that are associated with individuals who are having receptive anal intercourse or who have been abused. Proctitis is inflammation limited only to the distal portion of the rectum. And you can see the pathogens there. when the infection is higher up and involving the colonic mucosa, then these individuals also tend to present with more abdominal cramping and diarrhea, and can have some infections with some of the enteric organisms, as well as with chlamydia and some of the other STIs that we have talked about previously. I'm not going to spend any time on it because you've got a whole talk on STIs in terms of treatment, but the treatment is 100 milligrams twice daily for 3 weeks with doxycycline. All right, so from cervical screening to screening for STIs to routine vision and hearing screen. This is pretty straightforward, and basically you check an adolescent's vision 3 times during adolescence, and you only check hearing when he or she is symptomatic. So it's much more straightforward. Unfortunately, BMI assessment has become more and more important. These definitions are important for you to know, because on your boards, they're either going to give you a BMI and expect you to interpret it, or they are going to very carefully use the term overweight or obese. And your treatment for an overweight individual in some cases is going to be different than your treatment for an obese individual. So either via a growth chart or via additional information, either way, keep in mind that there is a difference between being overweight and being obese. And again, you know that the frequency of these issues has dramatically increased. So what should you do? If you are asked, when should you intervene with an individual who is struggling with his or her weight, it is at or above the 85th percentile. And that intervention should include evaluation of eating behaviors, elimination of energy-dense foods, elimination of or not elimination, but certainly a decrease in the intake of saturated fats, trans fats, cholesterol, etc. And you need to be careful here, because the recommendations are to maintain weight, not to necessarily lose weight, but to maintain weight in the absence of weight-related comorbidities, but to lose 1 to 2 pounds a week in the presence of a BMI that is above the 95th percentile and meets the definition of obesity. To limit sedentary activities, screen time, text time, etc., to under 2 hours a day, and to gradually build up to an hour a day of exercise. And you may be asked, I know this was covered in one of the other talks, about the various components of metabolic syndrome, but the reason that I bring this up here is if you see the components of metabolic syndrome, then the recommendation in terms of your board answer should drop from simply maintaining weight to an active weight loss recommendation. So obesity, dyslipidemia, hyperinsulinemia with eventual insulin resistance, with the consequences of type 2 diabetes, etc. So recognize the specific comorbidities that should change your recommendation in an individual who is overweight, from trying to maintain a particular weight to actively trying to lose 1 to 2 pounds per week. Annual screening for blood pressure is recommended. It's important that you know the definitions of hypertension, and keep in mind that pre-hypertension is defined as between the 90th and the 95th percentile, and then there are both stage 1 and stage 2 hypertension. And obviously this is based on the individual's gender, age, and height. But blood pressure screening is recommended at least annually in all adolescents. So what about cholesterol? When should you check cholesterol? So routine, non-fasting total cholesterol, note non-fasting, total cholesterol screening is recommended at what age? A, 11 to 12 in all patients, 11 to 12 years of age, repeated every other year, only in patients at increased risk, at 15 to 16 years of age, at 9 to 11, and then again at 17 to 21, or yearly in at-risk patients beginning at 11 years of age. Good. Okay, so the majority of you chose D, which is the correct answer. Routine screening at 9 to 11 and again at 17 to 21 years. Now, they may also ask, well, what are you screening with? What should you order and when? So it's important that you remember that the cholesterol screening can be non-fasting, but it's important also that you know when to test further. And if the HDL is above or equal to 145 or the HDL below 40, then it is recommended that you obtain 2 fasting lipid panels and average the results. Okay, so non-fasting to begin with, followed by 2 fasting if these particular criteria are met. And between those 2 age groups, it is recommended only to screen with lipids for individuals with specific risk factors, which again are pretty straightforward. A strong family history. If a parent is known to have a cholesterol level of above 240 or with significant dyslipidemia, or the individual adolescent has significant risk factors. But in the general population, the screening should only take place twice during the adolescent period. And the values are given here, and I give you these. When I talked yesterday with the individuals that are recertifying, I mentioned to them that a lot of times in a recertification question, you're told that this value is normal or this value is abnormal, whereas in your initial certification, you're oftentimes not given normal and abnormal values. And so you should be familiar with specific values that should prompt additional testing or specific values that would indicate that no additional testing is necessary. So these are the acceptable values, and these are the values that are considered abnormal. There's always a gray zone between the two. But in case you are asked how to proceed based upon a particular level, here's your answer. Hemoglobin and hematocrit screening is recommended routinely only one time, and that is when you're about 12 months old. Now, some states also require it at 2 years of age, especially if they are covered under Medicaid. But from an adolescent perspective, screening for anemia is based on risk assessment, and there are no recommendations to routinely screen all adolescents for anemia. But if you look at this list, I think it's fair to say that there are going to be a fair number of individual adolescents that you're going to be screening for anemia. Remember, in the GI lecture, I think it was the first lecture of the conference, vegetarians are at particular risk not only of iron deficiency, but also of B12 deficiency as well as zinc deficiency. So there are going to be a fair number of individuals based on these risk factors that you should obtain a hemoglobin. And most of the time, assuming that the risk factor does not change, you're going to be checking for anemia probably 3 times, early, mid, and late adolescence. But again, that's specific to the particular adolescent patient. And routine urinalysis screening is not recommended at all. Tuberculosis, tuberculin skin testing is certainly important to keep in mind. Targeted testing is recommended in the adolescent population in terms of the birth country or traveling to specific countries where the risk of tuberculosis is high, and others. Certainly if you see in a scenario on a board question the word incarcerated or the word homeless, you are being given a hint that TB is more likely. Now, the other thing we have to remember is what makes a tuberculin skin test positive. And that is not something that you can answer in a catch-all way. So it is considered positive if you have induration of 5 millimeters or more in these particular circumstances. And so close contact, clinical evidence, or an immunosuppressed condition. Induration of greater than 10 millimeters is considered positive in any chronically ill individual, again, in an individual who has traveled to or immigrated from a country with high endemic rates of tuberculosis, and exposure to high-risk adults. So I can easily imagine a question where they give you a scenario describing a patient in terms of where he or she lives or where he or she has traveled, who he or she lives with, and then they have a tuberculin skin testing measuring 8 millimeters. So for some, 8 millimeters is going to be positive. For others, 8 millimeters will not be considered positive. So these are important criteria for you to keep in mind. Interferon gamma release assays, the newer serum tests for tuberculosis, are especially useful in two circumstances that you might see on your boards. Number one, children under 4, and number 2, individuals who have had previous BCG vaccinations. So the whole dilemma of how to interpret a tuberculin skin test in an individual who's previously had a BCG vaccination is made much easier now that these serum tests are available. Finally, an induration of greater than 15 millimeters is considered positive in individuals who have no identifiable risk factors. Screening for mental and emotional health is strongly recommended, I think, for obvious reasons. There is not a particular screen that the Academy recommends. The Beck Depression Inventory is just an example of many of the various screening tools that are available. But this is recommended yearly, beginning just before adolescence, right through adolescence. And you've got to be familiar with the potential comorbidities that are associated with depression, and also be very familiar with 9 red flags. And again, I know you're familiar with these, but I can see these appearing on your boards. And so they are outlined here for you. Now, again, this doesn't directly relate, well, I think it does directly relate in some sense, but what I'm always trying to do is keep in my mind what board questions might you hear. And a very common board question is an adolescent who presents suddenly with a behavioral change, a decrease in school performance, and you're thinking, and they want you to think this, depression, or you're thinking substance abuse, and then they happen to say something like, and the liver functions are a little bit elevated. Or they show you a picture of an eye exam, and you see Kaiser-Fletcher rings associated with Wilson's disease. So Wilson's disease, this was mentioned in the previous talk, excess copper. Once the excess copper is no longer handled by the liver, it dumps into the system and deposits in the brain, causing significant behavioral changes. And I've seen that question a lot. They're trying to gear you away from the correct answer. There's high copper, there's low ceruloplasmin, because that's what carries the copper, and Kaiser-Fletcher rings. So that is a substance abuse lookalike, and the boards love lookalikes that you may see. So let's look a little bit at growth and development. I'm not going to spend a lot of time on this because you already have seen the Tanner stages. So just a couple of things that I've tried to pick out to keep in mind about Tanner that I think is important. We were all reminded of this yesterday or maybe the day before with the endocrine lecture, but you've got to know the size of a prepubertal testes, and that is less than 4 milliliters. That's important because they're going to give you testicular size. They're not going to talk about he's Tanner 2 or Tanner 3. So in these next few slides, I just tried to pick out one key thing to keep in mind as you're memorizing Tanner stages that I think will most likely appear on your boards. So there's a little bit of testicular growth during Tanner stage 2, and the key thing to remember here is this is the classic size of the testicle in an individual who they are presenting with Klinefelter syndrome. So it's 5 millimeters and it's firm. Those are the two key things to keep in mind about that. Testicular size is much more commonly going to appear on your boards than is penile length, which is really something that really kind of spills over just into the endocrinology subspecialty. The key thing about Tanner 3 for boys, this is the stage where gynecomastia is most commonly going to be seen. So you may have a scenario where different stages are described, and then it asks you, in which one of these patients is gynecomastia most likely to be identified? So they'll describe Tanner 2, Tanner 3, Tanner 4, etc. So know that gynecomastia appears in Tanner 3, and know that peak height velocity is in Tanner stage 4. Another very, very common question. So I think there are certain components as you study these Tanner stages that you should pay a special attention to that will hopefully help you sort out some of the questions. So same thing for young girls. It's in Tanner 2 that breast buds appear. Just like testicular enlargement is the first sign of puberty in boys, breast budding the first sign of puberty in young girls. And the peak height velocity is in Tanner 3 for girls as compared to Tanner 4 for boys. So girls grow taller when they're younger, and they finish their growth usually about 2 years prior to males. So peak height velocity, Tanner 3 rather than Tanner 4. And then the secondary mound is usually the key phrase that will help you identify that a particular young adolescent girl that they are describing is at Tanner stage 4. Okay, contraception. The contraceptive effectiveness is listed here. And I really doubt that you would ever be asked these percentages. Just the thing to keep in mind is that the theoretical efficacy of oral contraceptives versus the real-world efficacy, that's the one thing that you might be asked about. So it drops about 10%, again, obviously because of non-compliance. Condoms should always be recommended regardless of any other types of birth control that are being used. And it's important that you know the actions of oral contraceptives above and beyond inhibiting ovulation. So I would know these other effects of oral contraceptives because I can see that you might be asked about that. And there are lots of non-contraceptive benefits that you may be asked about in terms of dysmenorrhea, decreasing the pain associated with endometriitis, fibrocystic breast changes, perimenstrual breast pain, premenstrual dysphoric disorder. I can see several questions about in an individual who has chosen to take oral contraceptives, what other potential benefits may there be based upon her decision to do so. We're going to talk about eating disorders in a second, but oftentimes treatment of hypothalamic hypoestrogenism oral contraceptives are recommended, and that is exceedingly common in athletic adolescent girls as well as in girls with eating disorders. There are certain types of oral contraceptives that are especially useful in androgen excess disorders, along with spironolactone, which again was mentioned in one of the previous talks, and then reduced menstrual loss, number of days of bleeding, reduced risk of PID, pelvic inflammatory disease, a decrease in the risk of ovarian and endometrial cancer, and the like. So lots of potential benefits from the use of oral contraceptives in the adolescent population. Know the absolute contraindications. The one I think you're most likely going to be asked about is migraine with aura, and that's the key, with aura. With that aura, oftentimes, as you well know, come focal neurologic complications, and then pretty clear-cut any history of a thromboembolic event that the individual young woman may have had, liver disease, breast disease, and importantly, and unfortunately importantly, because this is not something that we would have expected to see in the adolescent population, but diabetes with end organ involvement. So in regards to oral contraceptives, know the non-contraceptive benefits and know the absolute contraindications. Now, which one of the following is known to decrease the efficacy of oral contraceptives? Rifampin, gabapentin, theophylline, montelukast, methylphenidate. Good. Okay, so rifampin is the correct answer, and one thing to keep in mind is that if you have an anticonvulsant, beware, because many anticonvulsants, not all, gabapentin being an exception, many anticonvulsants will decrease the efficacy of oral contraceptives. And in addition to rifampin, griseofulvin is thought to decrease the efficacy. And there are lots of other anecdotal reports about various antibiotics, but rifampin and griseofulvin are the two to remember. And so in a scenario where an individual who is on oral contraceptives is also on some other medications, the reason that they are giving you that information is probably related to the fact that the other medication is in some way decreasing the effectiveness of the oral contraceptive. Over-the-counter, especially St. John's wort, is an important one to keep in mind in terms of decreased efficacy. Individuals who are HIV positive being treated with antiretrovirals may be at risk of less adequate protection. And there are lots of other interactions that I think you should be aware of in terms of lowering the efficacy of various anti-inflammatories. Theophylline's not used very much anymore, and then reducing the clearance of benzodiazepines. Oral contraceptives and their effect on laboratory testing, another common question. And the big two groups are clotting factors and thyroid functions. And so if you are presented with a scenario of abnormal thyroid function tests, the key thing to remember is that although some of the thyroid functions may be abnormal, free T4 remains unchanged. And that's a key to help you differentiate, is this really thyroid disease, or is this simply an effect from the oral contraceptive? Clearly, with an increased risk of thromboembolic phenomena, the first 3 bullet points make sense. But I can see you be given a scenario where they're trying to lead you down the line of a thyroid problem, when in actuality it's just a change in the thyroid functions, not due to a thyroid problem, but rather due to oral contraceptives. They also decrease serum folate. And you may be asked about adverse effects and how do you address those adverse effects. So although irregular bleeding and spotting is pretty typical over the first couple of months after initiation of an oral contraceptive, you can see the various treatment options there in terms of either increasing the estrogen dose or changing the type of progesterone. Weight gain, again, changing the progesterone or lowering the dose. And amenorrhea, which is often resolved by changing to a higher dose estrogen pill. So you may be presented with a scenario where an individual wants to remain on an oral contraceptive, however, she's having significant side effects from that oral contraceptive, and you're asked, what should you do? Should you change the progesterone? Should you change the dose of estrogen in the pill? A new onset migraine with aura, again, discontinue it. That's an absolute contraindication. However, more frequent migraines without aura should be a precaution, but not an absolute contraindication. And you may, again, want to alter the dosages of estrogen or change the progesterone. You can see the remainder of the adverse effects here. But the importance of knowing the adverse effects is followed by how might I address those adverse effects in an individual who chooses not to have another form of contraceptive and wishes to remain on oral contraceptives. Emergency contraception is an important thing to remember. There are various medications available for emergency contraceptives, and very importantly, for your test, the AAP considers emergency contraception as a standard of care when exposed to the circumstances that are outlined on the slide. Pregnancy rates are generally reduced by almost 90% and should be taken no later than 5 days after intercourse. Know also that there are some differences in regards to what is and what is not available without prescription. And the adverse effects, the big one is nausea, so it is recommended that an antiemetic be prescribed along with the emergency contraceptives. And you might be asked a question following use of emergency contraception, which one of the following potential side effects are you most likely to see? And clearly that would be menstrual irregularities, even though all of these other side effects are relatively common. Not going to spend a lot of time on this. This is just data that I could see you being asked in terms of the percentages of individuals who are sexually active among the adolescent population. You can see them here. And the answer to the test is always support, counsel, prevention, and when necessary, treat. And again, in a confidential manner for all the reasons that we talked about earlier, with the important exception that if you feel that the sexually active adolescent is being forced to have sex, or there is a situation of abuse based upon the scenario that you're presented on your boards. Counseling should start early because, unfortunately, the average lag between initial sexual intercourse and any discussion with a physician tends to be about 6 months. And oftentimes, again, unfortunately, that discussion is prompted by a missed period. There are some definitions that you should be familiar with around the issues of gender identity. Remember also that if you are given a question that tells you that the individual is homosexual, know that that individual is at significant risk for a variety of issues and problems. And so just that information should automatically change. For example, your screening recommendations should make you much more sensitive to the fact that the individual may be homeless, for example. The individual is going to have an increased risk of emotional disorders such as depression and anxiety, as well as a considerably higher rate of suicide. In terms of definitions, I'm not going to sit here and read them, but these are terms that are going to be used on your boards, or they're going to be described on your boards, and you're going to be expected to know the definitions for gender identity, for gender role behavior, which is really driven by society and cultural expectations, for gender expression, how the individual gender is presented to the outside world, transvestism, gender dysphoria. I think that gender dysphoria may be something that you hear about, again, on your boards because of the increased incidence of depression and anxiety associated with some individuals with gender dysphoria, transsexual, and sexual orientation. So those are provided for your study because those are terms that you should be familiar with that are either going to be used in a description of a particular patient or you will be asked the definition. All right, so let's take some time and go through eating disorders. Now, the DSM-5 criteria are about the same as the DSM-4 criteria, but there are a few changes. So for anorexia, persistent restriction of energy intake leading to a significantly low body weight, an intense fear of gaining weight or becoming fat, or persistent behaviors that interfere with weight gain, and one or more of the following that are listed here. Now, importantly, the criteria of absence of 3 consecutive menstrual cycles is no longer included in the diagnostic criteria for anorexia nervosa. So the lifetime prevalence is maybe even a little higher than 0.5%. Some sources say 1%. Higher in Caucasian individuals and those of higher socioeconomic classes, although it's also increasing among various other ethnic minorities. Much more common in females as compared to males. And an important differentiation between anorexia and bulimia is its bimodal peak. The peak when young adolescent girls are, again, they're getting away from their family, peers are becoming more and more important, media has a tremendous influence on their opinions and who they want to look like and who they want to act like, and then a second peak at college entry. Very different than bulimia, which does not peak until around the time of college entry. And comorbidities, like so much else that we've been talking about, are very, very common. And substance abuse is not nearly as common in individuals who struggle with anorexia as is in individuals with bulimia. We'll talk about that a little bit more in a second. The symptoms that they may present to you are listed here. One scenario that you might keep your antenna up for, so to speak, is an individual who comes in complaining of decreased exercise tolerance. I can't run anymore. Or my shins hurt when I run. I can't go to the gym anymore. That's their chief complaint. Now, maybe they're going to give you a little information to try to trick you and say, well, maybe this is an asthmatic because of decreased exercise intolerance. But keep in mind that an anorexic patient is not going to present, in the vast majority of cases, saying, I'm struggling with my eating. They're going to present with a physical symptom that is concerning to them, and that physical symptom that is concerning to them oftentimes does not allow them to exercise as frequently or as long as they wish to do. The signs, again, the typical picture that you see is someone with 2 or 3 or 4 layers of clothing on them, but everything basically shuts down. So hypothermia, hypotension, bradycardia, and the like. Mitral valve prolapse, a new murmur of mitral valve prolapse, or the development of extremity edema. No evidence of estrogenation on examination of the external genitalia. So they're pink and dry rather than more moist like you would expect to see with estrogen. Desquamation, yellowing of the palms and soles, easy bruisability, and the loss of hair that is replaced by lanugo. So, which one of the following is most often important, most often identified in anorexic patients, and I'm going to add to this, who are also vomiting? Leukocytosis, increased levels of luteinizing hormone, hypokalemia, hyponatremia, elevated hemoglobin A1C. Good. Okay. We'll talk more about hypokalemia in a second, but just keep in mind whether it's a bulimic patient or an anorexic patient who is practicing purging, they are at risk for hypokalemia. Usually they are leukopenic, they might be anemic, there may be some thrombocytopenia, but the important thing to keep in mind is all of these laboratory parameters, with the exception of hypokalemia, are pretty rare. I can't tell you the number of times that I have set myself up for failure when dealing with an individual with anorexia and getting some labs, and then all those labs come back normal, and they look at me like, I told you everything was okay. And from a lab perspective, everything is okay. And so from an anticipatory guidance perspective, I've learned to say that I'm getting these labs to be sure, but most of the time they're going to be normal, and that doesn't mean that we don't have things to talk about. Because I have really lost a lot of ground more than once with that mistake. What happens with anorexic patients is this. They have a disorder called euthyroid hypothyroxanemia, okay? And what happens with this is that the total T4 and total T3 are abnormally low. What is not affected is TSH. So these individuals are indeed euthyroid, and if you are asked to evaluate someone that you think has anorexia and her TSH is abnormal, then they're not going to have anorexia. So the T4 is low, the T3 is low, TSH is normal, the free T4 is usually normal. It might be a little low, so focus on the TSH in individuals who may have anorexia. From an endocrine perspective, again, everything shuts down. Some evidence of hypothyroidism, and all of the gonadotropins are markedly decreased, which accounts for the hypoestrogenism that we mentioned earlier that oftentimes needs to be treated with oral contraceptives. if you use oral contraceptives in an individual with anorexia, it has no positive impact on the associated osteoporosis or osteopenia, and inducing menses in someone with an eating disorder along the lines of normal labs, a normal menstrual period may give that individual a sense of well-being when that is incorrect. So the artificial induction of menses is something that has no positive impact on osteoporosis, and as well, just like normal labs, normal menses may give them a false sense of well-being. Okay? So, hypokalemia and vomiting. However, remember also that hyponatremia may occur because of water loading. So I'm going to the doctor tomorrow, I'm just going to drink lots of water, I'm going to gain a couple of pounds, and they may actually become hyponatremic. As an aside, another board question, a hyponatremic adolescent who presents to the emergency room after partying, that's someone who took ecstasy. Ecstasy is known to cause increased fever and metabolism, and people who used ecstasy know to water load to try to decrease the side effects of ecstasy. So hyponatremia is an important metabolic abnormality in a couple of different scenarios in regards to adolescent medicine. They're dehydrated for pretty obvious reasons. They may develop fatty liver. Elevated cholesterol because of impaired lipoprotein metabolism. Another huge mistake I have made with patients over the years is because I always let them see the labs, and they'll go, my goodness, my cholesterol's up. And I try to take such good care of myself, and I eat well, and now my cholesterol's up. I've got to eat better. And so again, from a counseling standpoint, you need to be careful in regards to how the lab results are presented. And this is not from intake, but rather from impaired lipoprotein metabolism. The pigmentation that I mentioned earlier that you may see on the palms is associated with carotenemia, especially if the intake is limited to vegetables, and there may be an increase in amylase for individuals who are practicing purging. So what about bulimia? Bulimia is characterized by both the intake of large amounts of food within a discrete period of time, and importantly, a sense of lack of control during an episode. There are recurrent and inappropriate compensatory behaviors, usually centering around purging in order to prevent weight gain. These behaviors must occur weekly for at least 3 months, and self-evaluation is unduly influenced by body shape and weight. The majority of bulimic patients are average to slightly above average weight, a big difference between bulimic patients versus anorexic patients, but a similarity between anorexic and bulimic patients is a profound dissatisfaction with their physical appearance. And again, the disturbance is not related to anorexia. It is considerably more common, bulimia, as compared to anorexia. Some of the prevalent studies I've read have gone to high as 6 to 8%, becoming more common in males, as is anorexia, although 90% are female. And again, not a bimodal peak. Only this tends to peak around the time that individuals are beginning college or into young adulthood. Another difference is the association with high-risk behaviors, much more common in patients with bulimia as compared to anorexia, and a higher incidence of a history of physical and sexual abuse or neglect. There is a surprisingly high incidence of positive family history of anorexia. You go back and you talk to some moms of individuals who are struggling with anorexia, and after a relationship is established, they'll often share with their daughters, I struggled with this as well, or in fact, I still struggle with it. That family history is usually less common in bulimia, but what is more common is a history of abuse and definitely a history of high risk-taking behaviors, especially sexual promiscuity. And the behavior around the bulimic episodes is oftentimes around a period of boredom. So I'm alone this weekend, I don't really have anything to do, and the like. Physical symptoms can be a little bit different. Palpitations, chest pain. Beware of chest pain in a bulimic because that could be an indication of esophageal rupture, as would coughing up blood. So if you're presented with that scenario, that's what's going on, and it's obviously an emergent issue. Abdominal pain and bloating and spontaneous vomiting, very common. And then because of the various electrolyte abnormalities, weakness, cramping, tingling of the extremities. Parotid enlargement. Parotid enlargement is characteristic of individuals with bulimia. If you're shown a picture and you're trying to figure out, is that a lymph node or is that a parotid gland? Remember that the picture is going to allow you to see the angle of the jaw. And if the angle of the jaw is obscured, that's parotid enlargement. If the angle of the jaw is maintained, that's a high anterior cervical lymph node. And obviously your differential diagnosis is going to be far different. Physical signs, again, I mentioned before that the weight is usually normal to mildly overweight, parotid swelling, dental enamel dysplasia, a sort of a whitening or a yellowing of the teeth because of recurrent vomiting, and lacerations on the hands, so-called Russell's sign. And along with this, you may see soft palate petechiae. Because if the individual is inducing vomiting with his or her fingers, the fingers will scrape along the top of the teeth, causing superficial lacerations, and there'll be soft palate petechiae because of the trauma associated with the attempts to vomit. Gingivitis is oftentimes very common as well. And muscle weakness, diminished reflexes, again, because of some of the associated electrolyte abnormalities. So what are the associated electrolyte abnormalities? And the one you're going to see most common, and I think this is the one you're going to be tested on, is the hypokalemic, hypochloremic, metabolic alkalosis. And as I mentioned to some of you yesterday, this is the pyloric stenosis basic metabolic panel in an adolescent, because the same thing is going on in a 6-week-old with pyloric stenosis. So keep in mind this particular basic metabolic panel. And I hope you don't get questions like this, because I really dislike questions like this, but they'll give you a scenario and then they'll give you 5 different basic metabolic panels, and sodium's up in one and down in one, and they're oftentimes, at least for me, hard to work out. But this is a very characteristic basic metabolic panel that you need to keep in mind. Now, if there's laxative abuse, that makes the electrolyte abnormalities a little less predictable, as does diuretic abuse. And I don't think you're going to be asked about how a laxative versus a diuretic might change a basic metabolic panel, because as you can see, in some cases, certain electrolytes can go up, and in other cases, certain electrolytes can go down. The one you're going to be asked about for sure is this one. Now, again, for those of you who are certifying for the first time, oftentimes it's a more complex step-by-step question. And the example I used yesterday was an individual with a parotid gland enlargement. So they show you that picture. And then they say, in this individual, which one of the following electrocardiogram abnormalities are you most likely to see? So number one, you have to figure out its parotid enlargement. Number two, you have to remember that parotid enlargement is associated with bulimia. Number three, you have to remember that bulimia causes hypokalemia. And then number four, you can figure out the answer, which is the presence of a U wave secondary to hypokalemia. So as you prepare for your boards, think through the various steps with which you might be asked to come up with a particular diagnosis. And that's the major difference between recertification and initial certification, is the initial certification questions are usually multiple step versus the more one step, so to speak, for recertification. So peaked T waves, hyperkalemia, depressed T waves, especially if they take on this bimodal distribution, the so-called U wave, hypokalemia. So how do you manage these individuals? A multidisciplinary team with goals of acute medical stabilization, reversal of medical complications, and nutritional rehabilitation. And here's what the initial evaluation must include. Now, this is all pretty well straightforward. Now, one question that you're going to get out of this slide is, well, who needs acute medical stabilization in the hospital? So here's the answer to that question. So they might give you a scenario saying, well, which one of these individuals should be admitted to the hospital based on these particular findings? So the criteria for immediate hospitalization are listed here. Now, granted, it would be hard not to hospitalize anybody like this, but this is a very common scenario that the boards try to pick up on. So know these particular criteria in regards to who should not be treated on an outpatient basis, at least acutely, for his or her eating disorder. Now, the medical management will likely center around how much weight gain is okay and how much weight gain is too much. So you can see the definitions here, and the caloric requirements are here. And then also remember that the onset of menses and ovulation are typically not restored until about 90% ideal body weight. Which means prior to that time, that might be an indication for some additional estrogen therapy like we have talked about earlier. Now, the question that's going to center around feeding an individual with an eating disorder is the complication that's asked about on this question. So during the initial stages of increased caloric intake in hospitalized anorexic patients, which one of the following complications is most likely to occur? Hypophosphatemia, direct hyperbilirubinemia, hypercalcemia, hyperchloremia, or decreased levels of TSH. Great. Okay. So this was discussed in the GI lecture as well. But this is a very common question, and also in addition to knowing that it is hypophosphatemia, again, the way I remember it, they've not been eating enough, they need more energy. How does the body make energy? It uses ATP, so all the phosphorus is gobbled up and the phosphorus stays low. Gobbled up is probably not a very good term, but that's the general pediatrician rather than the metabolic lecture, so, which I thought was wonderful. So refeeding syndrome, be careful about that. Total body phosphorus is low, and they're going to describe the signs and symptoms associated with hypophosphatemia, and here they are. And the main one that you're going to hear described in your question will probably be a sudden change in mental status or the development of seizures. So again, rather than the one-step question of which electrolyte abnormality is going to happen, the two-step or three-step question might be, you now have a patient who in the ICU who is suddenly seizing during her initial hospitalization. So they give you a symptom, and then you have to remember the signs and symptoms of hypophosphatemia and then go and look for that. So refeeding syndrome, hypophosphatemia, important to keep in mind. Remember also that psychotropic medications are unfortunately not particularly helpful, especially in patients with anorexia, and especially in patients who are below the 80 to 85th percentile in terms of ideal body weight. And the female athletic triad is basically an individual with eating habits that do not meet the criteria for an eating disorder. So disordered eating is not an eating disorder. But that's an important differentiation. And then know also that disordered eating is associated with menstrual dysfunction, which is typically amenorrhea, and abnormal bone density. So let's look at medical issues in male. As again, male gynecomastia, Tanner stage 3, usually around age 14 years of age, typically asymmetric, oftentimes tender, and always very embarrassing and troubling to the young man. It's likely due to a decreased ratio of androgens to estrogen. And again, it's somewhat tender, usually asymmetric, and you can reassure the vast majority of patients that it will resolve. And oftentimes it doesn't take 3 years. It oftentimes resolves within a period of 12 to 18 months. This has been mentioned before, but remember the less common causes of gynecomastia. Certainly the syndrome to remember is Klinefelter's. Remember also that certain tumors can cause gynecomastia. Drugs of abuse, probably the two that are most common are marijuana and anabolic steroids. So a behavioral change, conjunctival injection, hanging out with a new group of friends. Oh, by the way, there's gynecomastia on physical exam. That's marijuana. That's amotivational syndrome, okay? Medications, here are the medications that can do it. So, a cremasteric reflex is typically absent in which one of the following? Hydrocele, torsion, epididymitis, varicocele, or spermatocele. Good. So testicular torsion, that's the correct answer. So let's look a little bit at some of the issues surrounding scrotal swelling. You can see the list here of the various disorders associated with scrotal swelling. We'll go through these. And note also that you can help with your differential diagnosis in terms of reading the question. Is this an acute problem? Is this a chronic problem? Is it painful? Is it painless? And with the exception of hernia, which can end up in any of the 4 boxes, this will help you to come up with your diagnosis. Pay also attention when you're reading the question to the timing, the location and intensity of the pain, dull, probably more typical epididymitis, acute and much more painful, more typical of torsion. Position of the testicle, we'll talk about that in a second, history of trauma, and any associated symptoms. So there's a total lack of associated systemic symptoms with, for example, torsion, clear presence of systemic symptoms with epididymitis. And remember how to perform the cremasteric reflex. So a hydrocele will be described as a soft, painless, asymptomatic mass anterior to the testes. Remember to keep in mind as you're reading the question, is the mass able to be differentiated from the testes or not? And then remember the location of the mass as it relates to the testes. So if it cannot be differentiated from the testicle, then it's likely a carcinoma. but the position, if it can be differentiated from the testicle, can vary between these disorders. So the hydrocele is anterior to the testes. It usually changes in size with changes in position. Another important clue as you read your question. And it may or may not be associated with a hernia. Transillumination is positive, but other things can transilluminate as well, so it is not specific for a hydrocele. Typically, a varicocele, almost always on the left. The typical description is a bag of worms resulting from incompetent venous valves in the internal spermatic veins. The majority are idiopathic. If it's on the right in your question, then that individual needs a workup. Okay, because that a right varicocele has a high risk of being associated with an abdominal mass that is obstructing blood flow. These increase with various maneuvers. That's in contrast to the hydrocele. So Valsalva will increase the size of a spermatocele. Again, much more common on the left, described as a bag of worms. And you might be asked, well, in what unusual cases do I need to intervene in an individual with a varicocele? And if the individual is having difficulty with infertility, or the patient has a single testicle, there's a size in testicle, there's a difference in testicle size, then that is an indication for repair. But it's a very, very rare need for that. Now, spermatocele will typically be described as located at the head of the epididymis. Again, you're going to have the option on your boards to choose between these, and I think it's the location that is the biggest hint as to what is going on, and a history of sort of a milky, fluid, spontaneous discharge oftentimes will bring the patient into the office because of embarrassment or concern and the like. And that's associated with a spermatocele, which is the most common cystic condition found in the scrotum. Generally not painful, and again, distinct from the testes, and this too transilluminates, which is why you can't depend on transillumination alone to identify some of these masses. And basically, the treatment for this is reassurance. So you might be asked, here are the options: Doppler ultrasound, refer to urology, et cetera. And, oftentimes when reassurance is given as an optional answer to a question, I'm always a little hesitant to say okay for reassurance, but it's oftentimes the right answer in many cases. Now, what about the acute scrotum? How do you differentiate between torsion and epididymitis? Testicular torsion versus torsion of the appendix, we'll talk about in a second. If you are able to identify that the source of pain is indeed the epididymis and not the testicle, then you're safe in treating that individual. But if you have any suspicion whatsoever that the location of the pain may also involve the testicle, then your answer is immediate referral to urology and not treatment or waiting. So sudden onset of severe pain, swelling of the testicle, and no history of trauma and no history of systemic symptoms. The other things about torsion are this: the cremasteric reflex is absent. The cremasteric reflex is present with epididymitis. The position of the testicle is abnormal in torsion and normal in epididymitis. The abnormal position in torsion is elevated and more horizontal rather than vertical. And then finally, the other difference you might be asked about is elevation of the scrotum improves pain with epididymitis, and it has no influence on the pain of torsion. So cremasteric reflex, position of the testicle, improvement of pain with elevation of the scrotum are the three things that you'll likely be asked about in regards to differentiating on a clinical basis between epididymitis and testicular torsion. And all that is outlined here for you. Remember that it's a surgical emergency, and the reason that it's a surgical emergency is that the viability of the testicle after 6 hours is markedly compromised. So this is why the answer to your question, the next best step in the treatment of this patient is refer to urology. If that is not an option, then your answer is emergent Doppler ultrasound, color Doppler ultrasound. Okay, because it's that color Doppler ultrasound that will evaluate whether or not there's increased flow to the involved testicle, which would be consistent with epididymitis, or decreased flow to the testicle, which would be consistent with torsion. And here are here's a summary again of what I just said, but it's definitely Doppler ultrasound with immediate emergent surgery or repair. Now, they love this. I would never, ever have the confidence to make this diagnosis. I'd be scared to death. But on your boards, you're supposed to know the difference between torsion of the appendix and torsion. So if you see blue dot, or if they show you a picture of a scrotum with a bluish discoloration, that bluish discoloration is a torsed testicular appendix. And the treatment for that is reassurance and watchful waiting, because these actually auto-infarct after a period of about 7 days or so. Now, but again, in the real world, at least as a general pediatrician, I would be very hesitant to make that call. But from a board perspective, if you see a description of a bluish discoloration or a well-localized tender area. Remember, spermatocele is not tender. A hydrocele is not tender. But a testicular appendix that has been torsed is indeed tender. Treatment for that, again, NSAIDs, analgesics, and elevation. Now, inflammation and swelling of the epididymis in a sexually active adolescent is usually due to the typical organisms associated with STIs. And remember, in men who have sex with men, there may be some enteric organisms that are the cause of epididymitis. So how does it present? Again, we've been through this before, and Pren's sign, P-R-E-H-N, is the sign that is associated with epididymitis. When you elevate the scrotum, that is considered a positive Pren's sign if the pain indeed is alleviated. And unlike torsion, these individuals have systemic symptoms. Unlike torsion, the pain is a little bit more dull and less acute, and the urinary symptoms would certainly be absent in anyone with testicular torsion. The workup for epididymitis along with your exam should be a workup for STIs. Again, using urine for testing of GC and chlamydia is a whole lot easier than getting a urethral sample. So unless there's actual urethral discharge without a urethral swab, you can get this diagnosis based on your urine samples like we talked about earlier. Okay, so orchitis is going to be unusual, but I think that orchitis might be an option for a male with an eating disorder who has parotid enlargement. So I can see that being a potential wrong choice on your exam. Usually associated with mumps, and supportive care is all that is indicated. All right, and then finally, neoplasms. Remember that testicular neoplasms are almost always malignant, and usually of germ cell origin. They're the most common solid tumor in young adults, more common in Caucasians, and much more common in individuals with a history of an undescended testicle, increasing the risk of neoplasm by up to 40 times. And again, the description will be a mass within rather than separate from the testicle. And oftentimes it is painless unless, because of necrosis and bleeding, pain is caused by those. So usually painless, but not always. And the survival in early stages is really much better than it has been in the past. Important for your boards, testicular self-examination is not recommended because of low incidence, increased anxiety, false positives, and the like. However, the caveat to that is there may be value of self-exam. So the board answer is testicular self-examination is not recommended. However, it may be important later in life. Same thing with breast self-exam, like we'll talk about in a second. Okay. Medical issues in females. So I mentioned earlier, breast self-exam, again, is not recommended in the adolescent age group. There's a low risk of malignancy. There's been lots of studies to demonstrate that there's no evidence of improved reduction in cancer risk. For obvious reasons, it increases anxiety. And importantly, false positives, just like pap smears, for example, in an 18-year-old, lead to unnecessary intervention and all the morbidity potentially associated with the methods of intervention. All right. If you do have an adolescent with a breast mass, the most likely diagnosis is a common cyst, and watchful waiting over 1 to 2 or 3 menstrual cycles is your choice in terms of recommended intervention. Mammography is not recommended. There's not enough fat tissue to make the study valid. So if imaging is ordered, ultrasound should be the image that's ordered, and a mass should only be aspirated if it is persisted for 2 to 3 months, and a excisional biopsy is almost never indicated. The exception to that would be a bloody aspirate. So the common cyst, the most likely mass, and if it's a firm mass and not cystic, it's going to be a fibroadenoma in the vast majority of cases, painless, firm, and rubbery. Usually distinct from the rest of the breast, oftentimes in the upper outer quadrant, common area also for fibrocystic changes. Fibroadenomas have no malignant potential at all. So reassurance, watchful waiting. In the rare case, if you need imaging, ultrasound, not mammography, and the only concern would be a bloody aspirate. And here's when you refer. All right, so amenorrhea. The players you're well familiar with, and let's try to sort through you'll get lots of questions on this. What's primary amenorrhea? What is the particular cause of amenorrhea and the like? So we need to spend some time on this. This is just in your handout for your review. And again, just as a reminder, gonadotropic releasing hormone leads to pituitary release of follicle stimulating hormone and luteinizing hormone, which act at the ovarian level. So, a very quick review of FSH and LH. So, menses indicate an intact axis. So, from the hypothalamus to the pituitary to the ovary, and importantly, to a normal anatomy, because we'll talk about this, but for example, if there's an imperforate hymen, amenorrhea may be the result of that, even though there's an intact axis. So it's important to always examine the genital area in an individual who presents with amenorrhea. So follicle-stimulating hormone stimulates recruitment of ovarian follicles and converts androgens to estrogens, whereas LH leads to androgen production in the ovarian theca cells, and importantly, we'll hear this over and over and over again, ovulation is stimulated by the mid-cycle surge. So the follicular phase, usually about 7 to 22 days, characterized by corpus luteum involution, decreasing levels of estrogen and progesterone, which lead to stimulation of gonadotropic releasing hormone, leading to FSH and LH. This brings about recruitment of ovarian follicles, endometrial proliferation, and keep this in mind that estrogens are responsible for endometrial proliferation. We'll talk about that a lot. And then the estrogens also trigger the mid-cycle LH surge, and that mid-cycle LH surge then leads to the ovulatory phase and ferning. And without that mid-cycle LH surge, you will, as we'll talk about, have unopposed estrogen stimulation of the endometrial lining, which is the most common cause of dysfunctional uterine bleeding, which we'll be talking about more in a second. Following the ovulatory phase, the luteal phase, estrogen and progesterone are produced by the corpus luteum, and through negative feedback lead to a decrease in FSH and LH. Endometrial growth ends and differentiates into a secretory phase. And again, without that LH surge, this isn't going to happen, and endometrial growth will continue. Cervical mucus thickens and no longer ferns. Involution of the corpus luteum. Corpus luteum produces local prostaglandins and some of the associated pain associated with menses and dysmenorrhea. All right, and again, for your review. So, terms to remember, just know these, so in case you're asked about it or in case one of these terms is used in a particular question, you know the definitions. And important definitions, I know you've seen this before, but primary amenorrhea, 15 years of age with normal growth and secondary sexual characteristics, or within 5 years of thelarchy in girls who began their breast development prior to 10 years of age. So that 5 years is important to keep in mind regardless of the age of thelarchy. Age 13 years in the absence of secondary sexual characteristics. I didn't include this because it's not included in all sources, but some sources also say the absence of menses by 14 years of age in an individual with the stigmata of Turner syndrome. But again, that does not appear in all of the sources. So, secondary amenorrhea is defined as a period of loss of menses for more than 3 months, or after establishment of normal menses, fewer than 9 within the previous 12 months. So, if I'm faced with a question about primary amenorrhea, there are different ways that I would suggest that you think about how to come up with the etiology. There'll be clues on physical exam. There'll be clues on laboratory. And there will also be clues based on breast development. So I want to look at amenorrhea from those 3 perspectives. What information can you gain from the physical exam? What information can you gain from certain laboratory results? And what information can you gain from the presence or absence of breast development? And I think if you consider all 3 of those, that will help you to sort through the myriad of things that can cause amenorrhea. So let's look at clues, first of all, on physical exam. You've heard a lot about Turner syndrome. Extremes in weight may delay menarche. So again, someone who's 85% or 80% of ideal body weight because of anorexia or because she's a gymnast or a long-distance runner, those are things to keep in mind just based on the information that you're given. Now, if there's breast development, remember that that's evidence of endogenous estrogen production. Now, the key finding that I want to point out is scant or absent pubic hair. If you see scant or absent pubic hair, think something's wrong with testosterone. And if something is wrong with testosterone, although these are both extraordinarily rare, they love to ask about them on the boards, think of androgen insensitivity syndrome. And what is associated with androgen insensitivity syndrome is the receptor gene mutation causes these individuals not to respond to testosterone. Compare that to the other one, which is Swyer syndrome. Again, is one of the, I think the endocrinology talk mentioned that she had never seen this, but it's always on boards. And that is patients who have testicles that have failed. So in androgen insensitivity, your testosterone will be increased, but you'll have scant pubic hair. And in Swyer syndrome, your testosterone will be absent or decreased, and you'll have scant pubic hair. So weight may be a clue. Presence or absence of breasts will be a clue because that tells you that estrogen is working. And a scant amount of pubic hair should raise your level of concern about androgen insensitivity or Swyer syndrome. What else on your physical exam? Anatomic amenorrhea is something that you need to keep in mind. And there may be an imperforate hymen, hematocolpus. The key to this is on your in your question, there'll be a mention of mom states that she thought her daughter was going to have a period over the last 2 or 3 months because she had pain, but the period never came. Well, the reason the period never came was because there's an anatomic obstruction to blood flow. So remember that scenario. If you hear it, or excuse me, if you read it, that's a big clue that it's an anatomic issue. Vaginal agenesis, transverse vaginal septum, absent uterus, far less common. And then also it's important to examine for evidence of estrogenation. Is the vaginal area moist, pink, and rugated, meaning there's estrogen, rather than smooth or pale, meaning there's no estrogen. Again, go back to the eating disorder that we talked about. In individuals with severe anorexia, they will have a lack of estrogenation in the genital exam. So those are some clues to keep in mind on physical exam. Is there breast development? Is there not? Is there pubic hair? Is there not? Are there clues that there are major issues in height, Turner syndrome, or weight, eating disorder, that will help me to sort through this? Now, what about labs? You're always going to get labs. What are particular clues on your laboratory evaluation for primary amenorrhea? Well, obviously, you need to rule out pregnancy. And a lot of this also has to do with secondary amenorrhea. Obviously, both primary and secondary amenorrhea can be due to pregnancy. It's important to rule out associated thyroid disorders. Now, what about FSH? If FSH is elevated, then that means ovarian failure. And the most common cause of ovarian failure is gonadal dysgenesis associated with Turner syndrome. So your first step would be to get a karyotype. What if your FSH is normal? So that means you have an intact axis. Then you should consider anatomic amenorrhea and get a pelvic ultrasound. What if FSH is low? That indicates a hypothalamic or pituitary cause, and that's when you order your MRI. So just like there are certain clues on your physical exam, there are certain clues on laboratory. What about clues that you can get from prolactin? Assuming that the patient is not on a medication known to increase prolactin, and assuming that thyroid functions are normal, you should always get a brain MRI to look for the possibility of a pituitary adenoma. So elevated prolactin typically means the next step is to get neuroimaging, assuming that the thyroid functions are okay and the patient isn't on a particular medication. Probably risperidone being the most common because that's used so often in adolescents with various behavioral disorders. So, when to get a brain MRI? Prolactin is high, low FSH, associated also with signs of delayed puberty. Now, that's from a physical exam standpoint. From a standpoint of labs, how about breast development? Because they oftentimes will describe breast development. So again, first rule out pregnancy, but this is primary amenorrhea, but they have described to you appropriate normal breast development. Again, think of drugs. Could it be constitutional growth delay or thyroid disease? Constitutional growth delay was discussed earlier, and we'll mention it again tomorrow when we talk about general peds issues. The anorexic patient, stress, exercise, weight loss. We have all seen patients with both primary and secondary amenorrhea who are long-distance runners, who have an eating disorder and the like, but their breast development is normal. Chronic illnesses and PCOS. Primary amenorrhea, breast development normal. What else can cause that? Again, outflow tract obstruction, like we talked about. Could it be premature ovarian failure? Could be, but again, that's a time when your FSH would be increased. A key, a history of a procedure, be it a D&C or other procedure. That procedure may cause adhesions. Those adhesions may lead to amenorrhea, anatomic amenorrhea, and that's called Asherman syndrome. And as you read your question, that is a key historical point that will help you. Maybe the uterus is absent, pelvic ultrasound, and again, we talked about the androgen insensitivities, and there might be a pituitary lesion as well. The other syndrome to remember is Sheehan's, and the key historical finding there is postpartum hemorrhage. So if you have an individual who had significant postpartum hemorrhage and then develops hypopituitarism, that is another key. So all these potential causes of primary amenorrhea are associated with normal breast development, as is PCOS. And we heard about PCOS yesterday, but remember the criteria for diagnosis include at least two of the following: oligo or anovulation, clinical or biochemical signs of hyperandrogenism. The clinical signs are listed here. And the biochemical signs you need to remember, and the most common one that's going to show up on your boards is a abnormal LH to FSH ratio, which by definition is 2.5 to 3 or higher. But all of your androgens are going to be increased. Your LH is going to be increased more than your FSH. And as was mentioned earlier, a fair number of individuals with PCOS may not benefit from an ultrasound because so many adolescents have a large number of cysts anyway. All right, so remember that anything that increases androgens will be hallmarks of PCOS, but there are other causes of androgen excess as well. But all of this is going to be associated with primary or secondary amenorrhea and normal breast development. Now, how about amenorrhea with varying degrees of breast development? In other words, there's no breast development or the breast development is less than you would expect. Again, Turner syndrome because the FSH is high. Acquired gonadal failure, either due to autoimmune issues or to iatrogenic issues. And again, the varying degrees of breast development depend upon when in the pubertal process the gonads fail. Or it may be genetic, and there are several genetic syndromes that are associated with menstrual irregularities. I'm going to just mention two things about Turner's. You've heard it over and over again, but the reason you're hearing it over and over again is it's popular. A Turner versus Noonan. They love lookalikes on your exam. And the Turner and Noonan lookalike is important to keep in mind. So Turner syndrome has left-sided cardiac lesions, coarc, bicuspid aortic valve, Noonan right-sided cardiac lesions. Noonan's, some degree of mental disabilities, not the case with Turner's. And certainly Turner syndrome is going to be all over your boards, just like it's been in numerous parts of these lectures. And here's the information on Noonan syndrome. Again, I don't mean to beat a dead horse, but you'll find that topics that are discussed by different individuals are topics that tend to be emphasized on your boards. Okay, now, we're almost done. Primary amenorrhea, varying degrees of breast development and normal genitalia. Again, constitutional growth delay, prolactinoma, Kallman syndrome. I know that, especially when I was a resident and younger, I wrote this a lot. Cranial nerves 2 through 12 intact. I never wrote cranial nerves 1 through 12 intact. I don't know, how many have tested smell in the last year? You know, not a lot. But if somebody tells you they can't smell, pay attention to it, because that's Kallman syndrome, and it is a very common board question. And here's a prolactinoma. Again, the most common pituitary cause of amenorrhea. Now, when you're checking your patient, also keep in mind that they're going to give you a blood pressure. And if the blood pressure is normal, then we've talked about what happens with a low FSH and a high FSH. But what we have not talked about is what if you have an elevated blood pressure. And this may slip by you. So pay attention to the blood pressure with someone with amenorrhea, because if it's elevated, that is a huge clue that the cause of the amenorrhea is due to late onset congenital adrenal hyperplasia associated with 17-alpha hydroxylase deficiency. So blood pressure will be an important thing to look at as you sort through this. Now, what if there's no breast development and an absent uterus? We've talked about this already. That's when you check your testosterone and your karyotypes, and we've looked at this already in terms of androgen insensitivity and Swyer syndrome. So those are 3 different ways to look at amenorrhea: from a clinical standpoint, from a biochemical standpoint, and from a standpoint of breast development. And if you keep those three things in mind, it will help you sort through what is a very long differential diagnosis. So now we're going to move into dysfunctional uterine bleeding, which does have some specific definitions that I think would be helpful for you to know. They are listed here and are basically centered around either the length of cycle or the length of a period of time of menstrual bleeding. And obviously, there's a good bit of variability in young adolescents in regards to frequency of menses. So that's why these definitions have been put forward. So by definition, it is described as irregular or prolonged vaginal bleeding due to loss of endometrial tissue. And I'll say this multiple times. It is due to loss, but incomplete loss of endometrial tissue, and that forms the basis for understanding what happens on a physiologic basis with dysfunctional bleeding. And it is always, well, I shouldn't say always, but it is certainly most commonly due to an immature hypothalamic pituitary axis. And that immaturity can last anywhere from as few as 12 to as many as 36 months. So again, there's great variability in regards to when a particular young woman establishes normal menses. Now, to think through why this happens, I think it's important to remind ourselves again of the various hormonal functions that we looked at yesterday. So here's the stepwise bits of information that I think you need to understand, and this is important even when talking with parents and young women. Why does primary dysfunctional bleeding occur? And again, this is from an anovulatory perspective. So there's no positive feedback of estrogen, and therefore there is no LH surge. Therefore, no ovulation, a corpus luteum is not formed, and importantly, progesterone is not produced. And what progesterone does is it stabilizes the endometrial lining. And what happens in the absence of progesterone is the endometrial lining continues in an unstable proliferative phase. And in that unstable proliferative phase, it will continue to grow until it outgrows a portion of its blood supply. Where it outgrows the portion of its blood supply along the endometrial lining is variable. So at times, tissue will be released from the endometrial lining, but it is never complete. It is always irregular from this area of the endometrial lining or that area of the endometrial lining. And so that bleeding is irregular, and that bleeding is inefficient in regards to allowing the endometrial lining to be totally cleared and prepared for the next menstrual cycle. So that's the underlying physiology behind why young women have at least a 12 or 36-month period of irregular bleeding, almost always due to anovulatory bleeding, but not always. And this was mentioned before in a lecture, but oftentimes disorders of coagulation will first present with dysfunctional bleeding, and the one to keep in mind for your boards is von Willebrand's disease. So this is a young adolescent who comes in with heavy menses, irregular menses, and you work them up and you discover that they have underlying von Willebrand disease. So keep that in mind as probably the most common cause of secondary dysfunctional bleeding. There are other factors to consider in the coagulation cascade that are listed here. But again, by far, von Willebrand's disease is what's likely to show up on your boards. Always consider thyroid dysfunction, again, PCOS, like we talked about earlier. We talked about the negative impact that eating disorders have on menses. Once you reach a critical weight, you're below that weight, you are not going to have menses. That can also be caused by excessive exercise and stress. If there's anything that makes you think that this dysfunctional bleeding is more acute and is more symptomatic, then you need to consider the possibility of an ectopic pregnancy or the possibility of pelvic inflammatory disease associated with an STI. One thing to keep in mind in regards to your boards is boards like to ask about perihepatitis or Fitzhugh-Curtis syndrome. And this is a young woman who presents with right upper quadrant pain because the hepatic capsule is inflamed. And that right upper quadrant pain oftentimes follows menses by a couple of days because the organisms, their STI organisms, chlamydia and gonorrhea, can gain entrance through an open os into the peritoneal cavity. So a sexually active woman on your boards with right upper quadrant pain, don't forget about Fitzhugh-Curtis syndrome as a relatively common presentation of an STI. And then certainly if there's an history of injury, then you need to keep that in mind as well. Treatment, if you get asked about treatment, base your answer on the hemoglobin value. And so treatment may be as benign as reassurance with suggestion of a multivitamin with iron to a somewhat more aggressive short-term use of an oral contraceptive to consideration even of hospitalization if there's any evidence of cardiovascular compromise, so a history of syncope, hypotension, and the like. So the treatment is based on two things. How symptomatic is the individual? That will drive whether you hospitalize or not, and how low the hemoglobin is, and that will drive how aggressive you get in regards to treatment with oral contraceptives. Now, dysmenorrhea is certainly a leading cause of school absenteeism. About 3/4 at least of young teenagers have dysmenorrhea. And importantly, dysmenorrhea is associated with ovulatory cycles. So in a woman with anovulatory dysfunctional bleeding, usually that bleeding is painless, unless it's due to one of those secondary causes. So don't get fooled if the patient is presenting with pain, because painful bleeding should lead you to the decision that this doesn't sound like anovulatory bleeding. This sounds like either a secondary cause, maybe it's an ectopic pregnancy, maybe it's pelvic inflammatory disease, or again, it is not going to be associated simply with anovulatory bleeding. So once dysmenorrhea occurs, then you can be relatively sure that ovulation is taking place. Myocardial contractions caused by prostaglandins are thought to be the reason behind dysmenorrhea. Leukotrienes may also be involved. And the symptoms are pretty straightforward. You're all familiar with them. However, if the symptoms are also, and we'll talk about this in a second, also associated with pain on defecation or rectal pain, then that is a key historical component that should make you think of endometriosis. Dysmenorrhea can also be caused by infection. We talked about Fitzhugh-Curtis. by endometritis or endometriosis and Asherman syndrome. Again, that, remember from yesterday, is an individual who's undergone a DNC, and because of the trauma associated with that procedure, has developed adhesions in the uterus. Non-gynecological causes should also be considered, and probably the one that's going to show up in your boards, I think, would be inflammatory bowel disease. So there may be a hint. For example, on pelvic exam, there's made mention of a anal fistula, which would make you think, for example, of Crohn's disease. If there's symptoms that are more compatible with a urinary tract infection, keep that in mind as well. Again, endometriosis, endometrial glands that are scattered throughout the pelvis may be a cause of secondary dysmenorrhea, and it's important to keep in mind that, again, rectal pain, oftentimes worsened by defecation, would be the key historical clue in your vignette on your boards. And also, young women with endometriosis do not respond nearly as well as one might expect to nonsteroidal anti-inflammatories and oral contraceptives, which are the two mainstays of treatment for young women with dysmenorrhea. So depending upon the information that you have in your vignette, you may want to consider a workup for infection with a SED rate or a CRP or a complete blood count, evaluate for chlamydia and gonorrhea, wet mounts if clinically indicated, looking for trichomonas. If an individual has trichomonas, it doesn't happen very often, but if it is present, and certainly if it's on your exam, what is described as a punctate or strawberry cervix, which are small petechiae around the os, is a good hint that trichomonas is going on. And if they tell you a vaginal pH, then that's probably going to be associated with bacterial vaginosis. And with bacterial vaginosis, the vaginal pH will be abnormal, and that means it will be above 4.5. Bacterial vaginosis, if they describe a clue cell or they show you a picture of a clue cell, epithelial cell that looks the way I described it, you take a sharp pencil and you sort of make little lines all around the periphery of the cell. So there may be hints in your scenario that this is a secondary cause, be it a pelvic inflammatory disease, trich, bacterial vaginosis, and the like. And again, the vast majority of young women respond to nonsteroidals. An additional number respond to oral contraceptives if nonsteroidals are initially ineffective. But again, want to emphasize that a lack of response should then give you an indication that the particular patient that they're presenting to you probably has a secondary cause of her dysmenorrhea. Okay, we'll finish the adolescent section very quickly. There's just a couple things about substance abuse that I think you should keep in mind. Know the statistics. The statistics are obviously pretty discouraging. These numbers vacillate some from year to year. Certainly marijuana is by far the most frequently substance that is abused. They like to ask this. Boys are more likely to drink. Girls are more likely to abuse tobacco. And then the stages of adolescent substance abuse, I think you should know, because I think that you might have a question that describes an adolescent's behavior. Is he or is he not seeking to buy drugs, or is he selling drugs, or are his grades bad, but otherwise he seems pretty much himself? And these various stages might be described, and then they'll ask you, at what stage would you say that this particular adolescent is? So it goes from experimentation to beginning to learn how not how, but to beginning to learn to enjoy the mood swing, moving into some drug-seeking behavior with increasingly negative consequences, and then dependence regardless, with no concern about the potential negative consequences that may occur. So screening for adolescent substance abuse looks very similar in some ways to screening for depression. So there's going to have to be a bit of information in the scenario that they present you to lead you to one area or the other. I think probably the one that I look at as most unique to substance abuse versus depression would be a new set of friends, no longer bringing friends home, hanging out with a new group, old friends are calling, where's Tom? He's not around, and the like. Otherwise, especially the first 5 bullets could certainly be compatible with depression again. And again, just to emphasize something I said yesterday, behavioral change, adolescent, don't forget about Wilson's disease. The CAGE questions for alcohol abuse can certainly be used, but in the most recent AAP Bright Futures publication, they specifically recommend that the CRAFT questions be used instead of the CAGE. Both the CAGE as well as the CRAFT require only one positive response to be considered a positive screening test. So I would be familiar with both of these. I don't think with the more recent AAP recommendation that CRAFT be used that would appear on your boards, but certainly you should be familiar with some of the various questionnaires for substance abuse. One thing to keep in mind that is oftentimes asked is they'll give you a list of drugs and they'll say which one of these drugs will be present in the urine for the longest period of time. And in chronic users of marijuana, you can get a positive drug screen up to 4 to 6 weeks out, whereas it's much shorter for the other substances of abuse. Very quickly, just a couple of highlights about each particular one. The individual who is described as just not caring anymore, sleeping more, hanging around the house, doesn't go to soccer practice anymore. All of those are consistent with anti-motivational syndrome. Remember also that marijuana is one of the drugs that causes gynecomastia, and it may cause some conjunctival injection as well. What I did with each of these, I picked out the ones that I thought you'd be most likely to be asked about, went through the adverse effects of each, as well as the effects of acute intoxication, because many times on your boards, the effects of acute intoxication will be centered around an urgent visit to the emergency department. In terms of cocaine, the main thing to remember about cocaine is these are individuals that will present with cardiac symptoms, maybe even an MI, and so a cardiac symptomatology, especially with hypertension and tachycardia, is probably going to be cocaine-related. In terms of amphetamines, the key thing that you might hear is a very poor dental hygiene, so-called meth mouth, where the teeth are not only yellow and stained, but there's actually a good bit of destruction as well from inhaling the methamphetamine. Ecstasy, I think I mentioned this yesterday. The scenario that oftentimes centers around ecstasy is the rave party, and this is the individual who is water loading. So just like yesterday we talked about anorexics, sometimes water loading, I also mentioned that with ecstasy abuse, water loading is a very common presentation into the emergency department, and usually the hyponatremic dehydration leads to seizure activity. And so what happens here is the individual abuser is well aware of the fact that hyperthermia is a side effect. Usually the rave party is full of a lot of people in a small room. It's hot. There are a lot of lights. And so water loading is a fairly common complication of the use of ecstasy. Opioids, on the other hand, should be thought through if there's evidence of respiratory depression. So very much unlike the other substances of abuse that we mentioned, keep that in mind for opiates. Individuals who have memory loss, who wake up in a strange place or have injury in the genital area, may be victims of the various date rape drugs that are listed here. And the scenario on your boards might be a confused young woman who was found in a stuporous state in her dorm room, for example. And then finally, inhalants. And the thing to keep in mind that might be the key for inhalants on a board question is perinasal and perioral rashes, because the inhalants are soaked on a particular cloth, put over the nose and put over the mouth to be inhaled. The other key might be significant rhinorrhea with inhalant abuse. So as you're reading through the acute presentation of an adolescent to the emergency department, paying close attention to blood pressure, close attention to the mental status of the individual, and these individual key findings that tend to be key words will help you sort through the particular issue. And finally, hallucinogens are here. The big thing about hallucinogens, they'll talk about nystagmus. And that's the thing to look for with those. Finally, anabolic steroids. This is, again, another presentation of an individual with a behavioral change, usually an athlete, oftentimes a football player, oftentimes a lineman, or a wrestler. When we talk about orthopedic problems in a little while, you can almost pick out which orthopedic problem they're presenting to you depending upon their sport. And so this is similar with anabolic steroids. A sport is always one where brief periods of maximum strength are involved. Weightlifters would be another example. Keys on physical exam that will help you to determine whether anabolic steroids are being abused would be small testicles and gynecomastia, acne, and additional hair growth. All of those things would be consistent with anabolic steroid abuse. Any labs would be related to the liver, and you might see liver enzyme elevation in certain individuals who have abused anabolic steroids. Okay.